Hi everyone, my patient was a 51-year-old African American male with a history of hypertension, diabetes, hyperlipidemia, and a CVA who presented to the emergency department unresponsive. The patient was found at home unresponsive by family and was down for an unknown amount of time prior to arrival. Per EMS, the patient had witnessed seizure en route to the emergency department, but no seizure activity was noted in the ED. The patient, shortly after arriving to the ED, lost a pulse. He was coded, and ROSC was achieved after 17 minutes. The rhythm during the initial arrest was PEA, and the patient returned to normal sinus rhythm post-arrest. His UDS was positive for cocaine. His CT scan showed multiple infarcts in the temporal, occipital, and parietal lobes with no mass effect or midline shift noted. The patient was intubated and on no sedation and still unresponsive to stimuli. The patient history has been obtained from the chart from previous encounters. Further HPI elements were unable to obtain due to the patient's status. The patient was then admitted to the medical ICU for further management. Per his previous visits, he had no known allergies, and his home medications were metoprolol, atorvastatin, aspirin, and metformin. And as I previously stated, his past medical history was hypertension, diabetes, high cholesterol, and a CVA. His past surgical history includes a cholecystectomy. His family history was unknown. It wasn't recorded in previous charts, and the patient's family did not accompany the patient to the emergency department. From the information we were able to gather from EMS prior to this incident, the patient was taking care of himself, alert and oriented, and ambulatory. His review of systems was unable to be obtained due to his status. For his physical exam, the patient was an ill-appearing African American male, appears the stated age that we had on file, and he appeared to be well-nourished. His neuroassessment was unresponsive. He was unable to answer questions due to being intubated. He was normocephalic, atraumatic, mucous membranes pink and moist and intact. His pupils were dilated and slightly reactive to light. His neck was supple, no masses, no JVD, no thyroidomegaly, and no lymphadenopathy or carotid bruit. He had a regular rate and rhythm. He was in normal sinus rhythm, no adventitious heart sounds. He had some +1 peripheral edema and cyanosis noted. His lungs were clear to auscultation bilaterally. His chest expansion was symmetrical. His abdomen was soft, non-tender, non-distended. Bowel sounds were active in all 4 quadrants. There were no masses. His skin was cool to touch. There was no diaphoresis, no rashes. He had normal skin turgor. Musculoskeletal, there was no purposeful movement in his upper or lower extremities. He did not follow commands. His vital signs, once he arrived to the medical ICU, his blood pressure was 99/72. His O2 sat was 98, pulse 78, respirations 24, temp of 93. For his diagnostic testing, his CT head, as I previously stated, had multiple acute infarcts in the temporal, occipital, and parietal lobes. His echo was pending. His chest x-ray showed that his lungs were clear bilaterally. There was satisfactory positioning of the ET tube, and his central venous line terminated in the superior vena cava. For his lab values, I'll just list the pertinent lab values. His white count was 27. His sodium was 151. His potassium on arrival to the emergency department was 8. His repeat potassium in the medical ICU was 4.3. Chloride was 106. CO2 was 14. His creatinine was 2.8. Glucose was 407, calcium 8.7, his osmo was 317, and his mag was 2.4. His ABG, once he arrived in the medical ICU, I don't have his original ABG from the emergency department, but his repeat ABG after being ventilated, his pH was 7.31, his CO2 was 32, his PO2 was 95, and his bicarb was 14. Which shows metabolic acidosis with concomitant respiratory alkalosis. His troponin was 2.1. His procalcitonin was 6, and his lactic acid was 10.5, which is to be expected after a cardiac arrest. He was negative for flu and negative for COVID as well. So his diagnoses were cardiac arrest, CVA related to cocaine use, acute kidney injury, sepsis, and cardiogenic shock versus septic shock. So the plan is as follows. For his cardiac arrest, he was on Levophed at 0.3 for hemodynamic stability. We put in an order to add vasopressin if necessary because his Levophed was maxed. We put in an order for cheetah monitoring to monitor hemodynamics. His SVO2 on his VBG was 42, so we started the inotrope butamine to increase his perfusion. He was mechanically ventilated on ACVC, respirations 24, tidal volumes 450, 50% FiO2, and a PEEP of 5. The original PO2 was greater than 300 because his initial vent settings included an FiO2 of 100%. So once he arrived to the medical ICU, we decreased his FiO2 to 50%, which corrected that problem. We also started a bicarb drip at 150 an hour to correct his bicarb of 14. We placed a left IJ CVL, a right femoral art line, and we also ordered an echo. For his infarcts, he was not a TPA candidate or an intervention candidate, so we ordered a repeat CT in 24 hours if the patient was stable enough for imaging at that time. For his acute kidney injury, his baseline creatinine was around 0.75. His creatinine post-arrest was greater than 2. So we chose to continue the bicarb and sterile water as his hydration because his sodium was 151. And then just to monitor his urine output after that and monitor his creatinine levels daily. We did consult nephrology before we got his repeat potassium of 4.3. Nephrology considered starting CRRT since his potassium was 8, but we then got a repeat potassium. It was 4.3, so no dialysis at all was needed at that time. He did have a Foley catheter. He did meet 3 out of 4 Sears criteria. For sepsis, his temp was 93, his white count was 27. And his respirations were 24, but that was due to the ventilator settings. There was no source of infection. His urine looked like he might have had a slight UTI, but it's probably unlikely. It was probably a dirty sample. But we did choose to cover him with broad-spectrum antibiotics with vancomycin. But his shock was most likely due to cardiogenic shock from his cardiac arrest. We did not initiate targeted temperature management because he was already 93 degrees at the time. For DVT prophylaxis, we put the patient on Lovenox. Ultimately, the patient's prognosis is very poor. We spoke to the family about goals of care, and he became a DNR after that.